This week on the BackTable podcast.
The Cook micropuncture set as an access for the pedal is just unbelievable. I don't use the 5 French or 4 French outer. I use the 3 French only as a placeholder, and you just let it sit there and dribble. It can leak it in whatever it wants, but never put a 4 or 5 French sheath in those vessels. They're so small. And you should put a 1/2 inch of nitro paste on the foot under a tegaderm or something overnight afterwards, just to give that rotten artery a chance, right? I've gotten into completely occluded DPs and got up into the AT and done my work and then come back and recanalize the completely occluded DP. That's not as common, but I'm hoping that the laser will be of some use in that regard because they're so small now that there's hope, I think.
Welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a quick word from our sponsor.
This episode is supported by Reflow Medical, makers of high-performance medical devices for peripheral and coronary interventions. Reflow's approach to finding solutions to unmet clinical needs is known as the innovation algorithm, where physicians work with Reflow in a continuous loop throughout development. Successes include the Wingman catheter for rapid CTO crossing, the SPECS LP low-profile support catheter for improved vascular access and crossing, and Cora catheters, a suite of tools for use in complex PCI procedures. The innovation algorithm, products that are physician-imagined, Reflow-engineered. For more information, visit reflowmedical.com. And now, back to the show.
Hello, everybody. Welcome to the BackTable podcast. I'm your host, Dr. Baheti. I'm coming to you from Tacoma, Washington today. Not as sunny as where our guest, Dr. Gregg Alzate, is coming from. Dr. Alzate is a senior interventional radiologist at Sharp Healthcare in San Diego, California. Thanks for coming on the show.
Hey, thanks for having me.
Okay, so I met Gregg at Western Angio this year, and I instantly knew he would be an amazing guest to have on. At a lecture I saw him give, he talked about what we are going to call the Alzate Retrograde Antegrade Maneuver, or the ARAM technique. Or no, we don't even have to say technique afterwards because it says maneuver. Yeah, I'm like the person that calls it a TIPS shunt. Yeah, no, the ARAM. Okay, we're going to talk about that technique a little bit. We're also going to get into a little bit about his practice and his career thus far, and some other stuff. So I'm super excited for the next hour. Okay, Gregg, let's just start a little bit about you, because not everybody knows how cool you are. I think only people in California know. So tell me a little bit about kind of what brought you to where you are today.
Hold up a timeout or something when you get tired of hearing. But listen, I grew up in Sacramento, and I thought that the universe ended 10 miles from where I grew up. So I was afraid to go to Berkeley or UCLA, and UC Davis took me. So I went there, and I wanted to be a doctor. And no one in my family had ever been a doctor. No one had ever graduated from college. There's 6 of us. And my father came from the Philippines in 1938 with his cousin. He was lucky to escape the plantations surrounding the Sacramento River, where a lot of Filipinos ended up. And he was a cook, and he was doing all right. And then he suddenly died. I think it was a PE, but we'll never know. Then, I went to medical school at UCSF. That was a complete fluke, but it was the top of the heap at the time, intensity that people exhibited there as your attendings and everything. It was very inspiring. I thought I wanted to be a surgeon, but I didn't have the intestinal fortitude to complete the 5 years as a beat up lieutenant, in the general surgery corps. And so when time came, I thought, maybe I could make a living in ER. So I applied to radiology ER, and I said, I'll just let it go, see what happens. And I got accepted at UC San Diego and not UCSF. I was heartbroken.
Get far away from Sacramento then, right?
Oh my God. So then I discovered in the first year that radiology was really pretty cool. It was a great intellectual environment. And I was working ERs at night to pay my bills. I was working as an ER physician. You could do that back then. So I was taking care of gunshot wounds, intubating overdoses, all kinds of things as in the middle of the night. And I would go to work the next day and do radiology. And So I realized pretty quickly that the adrenaline rush that I loved from ER was not going to be something that I could enjoy when I was 40. It's just too much, right? So I gravitated towards angiography at UC San Diego, and there wasn't much happening there, but I just loved blood, spurting blood involved in cases, the urgency, the immediacy. And we weren't doing a whole heck of a lot of life-saving crazy things then, but still, we did a few things, GI bleeds, you would do stuff like that, traumas. Yeah, I got to my fellowship and I had a choice to go to one of these total overwhelming, Miami or MD Anderson kind of places where you just be destroyed by volume. Maybe your attendings would be half interested in you. And I just decided I was staying at home. I would make the best of it. And I would do angio at UC San Diego. But halfway through that, they changed the call schedule. They promised this 1 in 3, and now was every other. And feeling pretty good. We're in one of the top programs in the country. We're very well thought of. We have paper trails to indicate that. We're like, oh, hell no, we're not going to do this. So maybe we'll just jump ship, The
old bait and switch call schedule. I like that. Yeah.
So then my program director, whom I had a really good relationship with, he's still alive. He's 90 and quite a remarkable guy, but he was a chest radiologist. He had no insight into my love of blood and pus. And so he said, okay, I'm going to send you across town to help out these 2 guys. And I knew one of them. He was a junior staff guy. He was at Harvard. He was likable, Irish guy. And the other guy I'd never heard of. So I say, well, okay, I'll do anything rather than be every other. You got to do something for me, and I want to be authentic. The number one thing I want out of my fellowship is I want to be able to walk in the room after I finish my fellowship at my first job ever and say, I know how to do this. I am competent to do it. It was a very important thing to me. So they send me over and I walk in to the most beautiful General Electric room you've ever saw in your life. It was, I think it's called the 9800 or something. It made everything I was working with at the university look like scrap. And I was in awe. It was like shock and awe. And Coons is standing there, he's doing his 10th biliary drainage that month. He's telling me there's a iliac angioplasty in the next room. Would you like to go do it? And the place was just alive. I mean, they were on fire. I had no idea who he knew. He knew Grunsing. He knew Plinio Rossi in Italy. He hung out with Tom Sauce. He knew everybody because he was striving to be recognized, right? In that time, he was becoming recognized, but I had no idea. So I was just there for the work. And so I learned a tremendous amount in a year. And then they said, well, we don't know if we need a third guy, but would you stay with no guarantee? And I said, sure I will. This will only make me better, right? And so they hired me at the end of that year. And then I just stayed forever. I've been there 40 years. And I cannot believe that. So
it's like, it's your home. Yeah.
Sure. We started out, we were on the cusp of gastrojejunostomy, renal stone extraction, IVC filter insertion without a surgeon. We were doing complex embolizations even then, but we would do anything we could get our hands on. The percutaneous abscess drainage was taking off and biopsy was already a thing. And we understood CT guidance and we weren't that great at ultrasound, but the biliary drainage, because of Coons' work, he was interested in that. It was pouring through the doors. And so people would come in their private helicopter to get drained by him, even though there was no treatment for what they had. They would come in and land on the hospital roof, He saved, I told this story at Western Angio. He saved a 2-year-old liver transplant patient at Children's, and Children's threw a SeaWorld party for him. He's in a tuxedo with the kid on his knee, and camera's rolling. He's on TV. It's 1986. No one's ever heard of an interventional radiologist, and he's like the star. And I didn't want to be a star. I wanted to be competent, and I wanted to start my family. So it was just amazing to be around these people. And the practice just kept rolling. 10 years later, he bails all of a sudden. he's got radiation injury to his eyes and his hands, and he's got to go. We're standing there, and they're saying, should we do a national search? I said, wait, look, I've been here for 10 years. I've done everything I can to be as good as I can be. And so I just waited. And in about 6 months, they never said another word. And so we just kept rolling. And I think we're clearly one of the biggest practices in the West. The volume, 7 guys, almost working full time. I'm the one who gets to work full time because I refuse to do more mundane things. But I love the work, and we're still going. We do more ablations than anybody in the region. We do more embolizations than anybody in the region. All the things that I consider to be the key things. We're doing stroke. We're doing it well. We are comparable to the full comprehensive stroke center across town. Our numbers are just right there with them, and we don't have biplane. We don't have the extra year. We're just going, right? And so in that respect, I think, it's about wanting to evolve and stay current and be something that would be truly useful. I get bugged by colleagues who come out of fellowship and say, this is all I am. I'm never going to be that. They'll say, I didn't sign up for it. And I think that's horrible. I mean, look, I didn't sign up to become the black toe, bad leg guy of the region. But I had kind of evolved to be that guy. But I didn't. Yeah. That wasn't in my dreams. But once you get locked into some intellectual interest and you see that other people aren't able to follow easily and that you find it simple, it's like organic chemistry. I used to say that it spoke to me. And some of my friends in med school would say, oh my God, I thought I would die. It was like Sanskrit. And I was like, no, it spoke to me. And so vascular stuff speaks to me. And I just find it so natural.
Let's kind of delve into that a little bit. Like, how did you become the vascular person for your practice? And how long ago was it?
Okay, so Coons already had rolled on that. He had a deal with back in 83, there's a cardiothoracic surgeon who's the dominant organism in San Diego County. He owns it. He is so good. And he's at sharp. Well, he could give a rat about a bad leg, okay? He's putting in valves and he's doing big things every day. Medicare paid, I could be a little off, but Medicare paid $5,000 for the first graft. Think about that. This is 1980. Yeah. You can triple that today, right? So he's super powerful, and he says, you just do all of our legs, Hal. Iliac angioplasty, iliac stent, you just do that. And then there'd be other cardiac surgeons who would say, you can do anything, but don't touch my SFAs. I'm doing Fem-Pop. Whether it's an hourglass, 1 hourglass, or 20 of them, I'm doing this. And so we had those guys. And then we had another guy who was a vascular surgeon trained at elite institutions, but he did not operate. He was really interested in running a non-invasive lab. That was his thing. He was rich otherwise. He didn't need the stress. And everybody said around him who loved him, they said, he's not a very good operator. So he was feeding us a vast number of patients from East County, a place called El Centro. They were generally Hispanic, laborers, blue-collar folks, and they were very sick because the American diet makes you very sick. He was doing non-invasives, doing physicals, and sending them to the hospital. And then they'd work them up for coronary disease, and then peripheral disease, and then carotid disease. That was the thing. Then we had another group. So it's 3 main feeders. We had an in-house HMO. It was like Kaiser. So these guys are paid by a foundation. So they're not incentivized to eat what you kill. They're not interested in more numbers. They have a badge, and the badge entitles them to a salary. And so guess what they wanted to do?
Not operate, not do cases. Gotcha.
Right.
Yeah.
And so they opened the door and we were flooded with stuff. So we had this probably baseline 400 to 600 vascular cases a year. And if you were interested, you could just go. You could just do what you wanted. And that's kind of what I did. I found it fascinating. And then after a while, like people would say, oh, I don't want to do that. Let Gregg do it. For example, we had so many limb salvage cases and I call them limb salvage, that's my word, from East County that I was doing 50 Tibial-Peroneal angioplasties with the Savvy balloon by Cordis. I don't know who ever developed that balloon, but it was perfect on an O1A wire, right? And so my guy would send me these bad feet, and I would say, looks like I could get to the anterior tib distally. I'm going to try. And I wouldn't call him and ask him permission. I would just go do it, right? And so he loved that. His limbs started doing really well, but there was no one to talk to. And so I threw my own dinner at Western Angio in the late 80s, and I invited a number of people from Western Angio, private dinner, and I said, hey, I got 30 guys in the room. Hey, who's doing this? No one.
Wow.
One hand, right?
Okay.
And I said, well, my practice is doing over 100 tibial-peroneal angioplasties a year. I'm doing half, and my other 5 partners are doing the other. And I said, they're just coming, and I have to do them, and I think we're doing good things. And so, that led to that. And then, by the time I was looking enviously at the guys at Stanford, because I kept close track with those guys were magical. It was Dake, Key, Z, Ravasi. I'm making a shambles of the name, but these guys were all over thrombolysis, as were we. We were doing 75 to 100 cold limbs a year. The surgeons had given up trying to do thrombectomy or revision of Fem-Pop grafts. We just put in the lysis drug and we opened them, and then we fixed the proximal or distal anastomosis, whatever it was. Or we said, there's nothing left for run off your toast, whatever. They just gave up on all that. So now we have the chance to do every SFA that we want. And so I was anxiously waiting for the Viabon trial to release the device in the 2001 SIR in Baltimore. I remember it very well. I went there to present 100 cases of thrombolysis using TPA because we had urokinase taken away from us. And I learned at that meeting that there were only 3 practices that had that kind of volume. One was in Peoria, Castaneda, Zuniga, and us and somebody else. And it was the real thing. I mean, we were that busy. And I began to realize that we were part of something really big. And so then Viabon got released for public use at that meeting. And I ran over to the Viabon stand and I said, hey, I want you at my shop in 2 weeks. And I want you to bring your devices because I'm ready. And in that year, I did 100 20 to 40 centimeter CTOs of the femoral artery with their devices. 20 to 40 centimeters. This is long disease.
That's no
right?
joke. Yeah, that's like you need a stent graft. Yeah.
The rep, he was a very cool guy. The rep was salesman of the year for Gore, and he got an SUV. A Mercedes SUV. And I never published it because I was too busy. I had a family. I was not interested in that. Sooner or later, the randomized controlled trial out of Dallas came out and said it's a functional equivalent of a Fem-Pop graft. That's all I needed. That's all I needed because that's what I believe, right? And I was way out in front about that. But it didn't take hold because the cardiologists who are now entering our space in the early odds were afraid to go more than 6 French. They just couldn't do it. Oh my God, how are we going to do this? And by then I had already learned via Gore Angioseal on the way to learning AAAs, right? Again, Katzen said, no one's going to do AAAs in America because the surgeons were all going to get it, blah, blah, blah. And Gore took me out to Houston and I saw it. We learned it. Went back home, we're off to the races, right? 50 or more AAAs a year. But I learned how to close an artery with Angioseal, and that was like magic, right? Oh my God. Now I can close any 7 French. You can go to 7 French with a 6 French Angioseal any day you want, just like you can go to 10 French with an 8 French Angioseal most of the time. That became this thing. And so then Perclose came along, and then I can go to 12. I can go to 20 by myself in my own lab. The surgeon doesn't have to be standing there holding my hand. Instead, I started doing crazy iliac interventions where I'd stent an iliac artery aneurysm that was huge. I'd cover the front end and the back end with normal size and in between it with thrombose. And one thing led to another. And I was like, suddenly I was this guy that would do a percutaneous aorta bifemoral graft, And all the while, I was criticizing my colleagues down the hall for using bare metal stents where they were using the term. This is one of my things that I just rant about. Kissing stent, okay? Now, Ring popularized that sometime in the 80s, but it's wrong today, right? You cannot put bare metal and recreate a distal aorta. You're jailing off going around the horn, but they still do it. And they use the word kissing stents like they're doing God's work, and they are not. They are ruining it for anybody but a very skilled antegrade stick guy, or like I do, antegrade to retrograde or retrograde to
There
antegrade.
you go. Yeah, yeah.
But I hate that they'll destroy that aspect of access, and they don't even think about it because it's been codified in the language, and it's just wrong. Let me just step back for a second. When I was at RSNA in 1988 or something like that, presenting gastrojejunoscopy, my 50 cases or something, there was a very famous guy. His name was Don Shorten. He was the god of tibial-peroneal angioplasty. And his famous thing was never, ever go below the knee to fix anything unless
and he was
it's
the
limb
god
salvage.
of tibial-peroneal
Yes.
only if it's limb
It
salvage.
had to be,
Okay.
you could never treat a claudicat with, tibial-peroneal angioplasty. Never do it. Look, he was just wrong. He was wrong.
This is very controversial, Greg. This is still something that, a lot of people have very strong opinions about, whether you treat claudicants.
They're living in the past. What are those things called? There's the Colorado guy. You rate vascular disease based upon the iliac stenosis.
Oh, the task guidelines? No.
It's a thing where they'll say he has something level 3. That says nothing about the individual case. And they will say, oh, this is good for stenting. This is good for angioplasty, or this is surgery only. That's all bullshit if you're talking about endovascular treatment as it currently exists, right? Endovascular stuff can do amazing things if you have the skill, right? And so we get stuck in this dogma, and it's 10 years old, right? It's 15 years old. Just like, oh, I can't go above the 6 French sheath because I can't close it. Well, dual per close makes you powerful. You can now do anything. And in fact, one of my arguments about peripheral embolectomy now is, hey, if you're going to really do a great job on a leg full of clot, arterial clot, why don't you just drop in a 12, dual per close, go around the horn, and you can have at it all day long with an 8 French bolt or whatever penumbra calls it these days, these fabulous suction devices, right?
Yeah,
they
exactly.
work.
Yeah.
But everybody's trying to stay under 6 French. It's nonsense. You don't have to be 6 French anymore. You can be big as you want to be, right? And safe. And sure at the end, right?
Well, so yeah, I think this is a great time to transition and talk about the technique that we talked about, the ARAM, right? Or no, what are we calling it?
Just ARAM. We're going to say
the
ARAM.
ARAM. Okay, that's like
that.
a little more, yeah. Like, when did you first start doing it? And then we'll kind of get into the specifics about it.
Okay. So that trick was taught to me by one of the guys who was a junior professor at UCSD who just saw it as a way to maybe study a trauma patient's leg after you did the embolization of the pelvic artery, because he did a lot of trauma at Santa Clara Valley Medical Center. But he had no idea where I was going to go with this, and I didn't either, except that I would use it to demonstrate more beautifully the tibial-peroneal runoff in somebody who was moving around. Like, I would get right down into the popliteal artery, and I would put the catheter, and then I'd say, hold still, and we would then get beautiful images. Maybe the first runoff, they were moving around. You know, there's always that levitation when the heat hits the arteries, or the sensation of heat. It's 2001 or something like that. I was probably using late 90s, but 2001 is the one I remember very well, because I had a very obese woman come to me. She said, I want to walk at my grandchild's graduation, and she's had bilateral 20 centimeter occlusions, SFA. And I said, well, I don't want to come back on you twice. So this is one of those memorable things. I started out contralateral and did her left leg. And then I said, well, listen, I'm going to save you a trip back. I'm just going to go down and do the other side. So I did 2 25 centimeter Viabond segments, one in each leg, one hole, 1 6 French hole. That's just a very powerful thing. And so you just do it over and over again in limb salvage. Let's step back and say, well, what was the standard approach for aortogram runoff, or by IR-derived endovascular. It was an abdominal aortogram, bilateral pelvic oblique arteriograms, and then a runoff. That was a complete study. Well, what do our cardiology colleagues do now as a standard? Nothing close. They hardly look at the aorta. They stare at things in one plane. They do cine when digital's been around for 30 years. And so they don't see jack. And if you do limb salvage, you have to see the pedal arteries. You have to see them extraordinarily well. You know what the targets? What are the targets? So I realized that, okay, most of these people are bad renal function. You got to minimize the contrast. You have to be thoughtful. So now it's not both legs at once. You don't even need to do the diagnostic study. What is the problem leg? Let's go at that. So save a little time. Let's go up, see the aortoiliac junction, and down to the common femoral. And then let's flip it. All right. And then we'll go down and do the hard work.
So, okay. So like walk me through, okay, you do you access, and then what do you do?
Okay. So you put a pigtail up, you do a distal aortogram.
Okay.
And if you are troubled by either side, you get the oblique to show that. Then you use the pigtail to throw your Benson across the aortic bifurcation, ask for sauce, run it over the aortic bifurcation, push it up, and then with the Benson sticking out about 5 centimeters, you just drag it down. I sent you a movie.
Is it okay if I post that?
Oh, for
Can
sure.
I put that? Okay, so folks can see it in real time. Okay, so then you have your sauce, and then you drag it down into the ipsilateral.
Drag it down with the Benson sticking out about 5 centimeters. Okay, so now you got to do an oblique view. So you do a roadmap. You see, oh, there's the SFA. Okay, that's where I'm going. And so you carefully bring it down, and you have to bring the sheath with you, because I always work with a sheath, 10 centimeter standard sheath. The sheath's going to have to be backed out a little bit, but there's going to be a moment, which your haptic sense will tell you, the sauce will just click. It will sort of just seat on the anterior surface of the common femoral artery, and it will be 3 or 4 centimeters inside the SFA. You don't move the wire until then. Then you advance the wire, and the wire should make the sauce just kind of arc. And you'll see that in the movie. And that's it. Now you own that direction, okay? Now you can pull out your sheath, have your tech put it together again, and then with the wire in the proper location, not down here. You're not doing a U. You're now sliding in.
You have it straight. You have it kind of straight heading downwards now.
The way it's supposed to be. And then you slide it in and you own it. Now you can go up in size, whatever. But this allows you the proper torque control of your catheter to get through difficult occlusions and stenoses in the tibial-peroneals and the SFA. And it is super efficient, right? When I did this at the meeting, when you draw the path from contralateral to tibial-peroneal vessel, you start at the common femoral, you go down, you go up, you go down again, you go up, and then you go 50 centimeters this way. What kind of control, torque control, do you have in that setting? Not much. This is why my cardiology colleagues fail all day long, right? They get down there, they can't figure out anything, right? They don't know why, all right? So if I'm struggling with an SFA for 5 or 10 minutes, I say, okay, the foot's been prepped already. Give me the ultrasound, micropuncture, go backwards, send an Advantage 018 wire backwards. Those things are amazing. They stay in the true lumen. They'll go all the way to the common femoral. They'll go all the way to where you need to be met. And then you snare it, pull it out, and you own it. But let's back up a minute. Everybody's large these days, right? America is struggling with obesity. And so you can't do an antegrade on a 300-pounder. It's not going to work. So you have to do what I'm talking about, the retrograde antegrade maneuver. You have to start retrograde, but vertical. Your first puncture is vertical. That allows the sheath to go both ways. If you have too much angle on it, you're going to have a V, and there's going to be too much friction, too much tissue, too much distance, right? That can really hurt you. But if you start vertical every time, the wire wants to go retrograde. So that's what happens. 1 in 50, I'll end up with an antegrade wire. I'll just pull it out and start over again, right? So you go up, you're vertical, you come down. And then angioceal, 6-French angioceal works beautifully up to 7-French in that setting. Beautifully. If you pay attention to how they tell you to use it, right? When you push it in and you get blood out the side, you're in 1 centimeter, right? And if you pull it back out 1 centimeter, the blood should stop. Well, that simple maneuver will absolutely make you a genius for the angioceal. But people don't pay attention, and they push it too far, and they drop it in the SFA origin, or they do through the back wall. There's all kinds of variation. I'm not going to lie, I've had 5 or 10 of those over the years in the last 20 years, but I'm taking, everybody gets overconfident. I'll take a flyer. I'll say, I can do this 5 millimeter vessel. And sometimes you just can't. And so you'll end up with a problem. But the first thing to do is if you're in doubt, order a Doppler 2 hours after your study. So it's 1 o'clock in the afternoon. And if you have a problem, you'll know right now. You can call your surgeon and say, dude, I'm sorry. And they'll fix it for you. And there'll be any recriminations, But those are the big things. Some of these really large people have done incredible things on, if you just pay attention to that, vertical at the beginning, and then go either way you want. I was in the Society of Vascular Surgery meeting in 2008. I'll never forget it. They had all these young lions that had just been appointed to be the chiefs of endovascular, WashU, Pittsburgh. And they're all sort of 40-something, and they all look very important. This one woman stood up and said, I really like to cut down on the common femoral. That way you can go either way. And I want to stand up and say, you are so, this is so sad. You're still talking about cutting down. Cutting down. You don't need to cut down 90% of the time, right? You can do this, and it works. And it gives you options. Everybody should get good at retrograde pedal. It's stupid simple.
That's a skill set you have to do if you're doing CLI. 100%. And it's like 100%. Totally something that we can all do as IRs. I mean, there's no reason not to. I want to ask a couple other follow-up questions so our audience can really start using this technique. You mentioned having a very vertical puncture and making sure that the artery is big enough. Are there any other things to look out for, like in terms of artery size, like calcium, things like that, when you're trying to do your puncture?
I think that calcium it can be a real bugaboo, but it's worked in many occasions without any problems. I think that the hard part in using this technique is when there's a stump and the SFA stump is close. Yeah. But that's still absolutely doable. And I'm an advocate. So what's your number one, weapon, right? It's the hydrophilic vert catheter by Cook. I've been using that forever. And if you pair that with a straight 035 Terumo glide wire, you can go all the way to the dorsalis pedis through a completely occluded system. It's unbelievable. If you try a non-hydrophilic angled vert, you'll get stuck halfway. You won't be able to move. But the hydrophilic is unbelievable. That material has axial loading that is remarkable. And when you add the hydrophilic aspect of the Terumo straight, it's unbelievable. The thing I like about the Terumo straight is it chooses the lumen. It does not coil up. You don't coil up in anybody's subintima, okay? There was a lot of that crap going on in the 90s, subintimal recalibration. Nonsense. Turn 360 degrees, find your path. If the wire is linear, follow it. If it's coiled up, don't follow it, right? You're not in the right place. And that works in iliacs. It works all over the place.
Okay, so straight Terumo glide wire and then hydrophilic 5 French vert. That's your jam for crossing CTOs. Okay, specifically. Got it. Yeah.
So when you get down into the tibial-peroneal, that 035 may go all the way, but now you're really having resistance, right? So it's time to stop, pull out your straight glide, and put in a Terumo 014 or 018 wire. And the path for that has already been dotted. And oftentimes, you're stuck at the tibio-peroneal origin, the wire will just fly. And then now you own it. Or you can come retrograde, snare it, and now you own the whole thing, right?
Okay, yeah, so that's kind of helps me understand your escalation strategy. What about like the really calcified CTOs that your glide wire won't go through? What do you like to use for that? You're like, I don't get those because I cross all my lesions.
Well, occasionally I have it, but that's pretty rare. I have to say, I will go to the back end of a Terumo if I'm stuck. But if I'm really stuck antegrade with heavy calcium, I'll go retrograde. And usually there's something about it. It gives away. You can stick an occluded, I want to make this point. You can stick an occluded vessel anywhere and use it as a conduit to get you a wire someplace. Like if you can't get into the SFA somehow, you can stick the occluded SFA, go backwards with an ONA wire, and then pull yourself out, leaving the 3 French Cook micropuncture catheter as a placeholder.
Mm-hmm.
And you can go on with your business. All you need is get started past that cap, and things will work for you. And you can thrombolize with that little 3 French thing in there overnight. It's not a bleeding problem. 3 French is almost nothing, right? And so you can leave that as a placeholder, and you can just keep working.
Did you just like make up a great catchphrase, like 3 French is no French, basically?
That would be wonderful. I could put that on my next T-shirt line. Yeah. But honestly, the Cook micropuncture set as an access for the pedal is just unbelievable. I don't use the 5 French or 4 French outer. I use the 3 French only as a placeholder, and you just let it sit there and dribble. It can leak it in whatever it wants. But never put a 4 or 5 French sheath in those vessels. They're so small.
Especially in the CLI patients, for sure.
And you should put a 1/2 inch of nitro paste on the foot under a tegaderm or something overnight afterwards, just to give that rotten artery a chance, right? I've gotten into completely occluded DPs and got up into the AT and done my work and then come back and recanalize the completely occluded DP. That's not as common, but I'm hoping that the laser will be of some use in that regard, because they're so small now that there's hope, I think.
Well, cool. Yeah. Okay. I think we like covered the technique pretty much. Like, is there anything else that you think that folks should know about it?
I have 6 elite guys here, and they can do anything. They're amazing, but they are slow adopters. They're not really hot for this because they feel like they're going to lose their access. And my encouragement is know where your entry site is and have your sauce in the proper location, and you'll see it when it seats on the anterior surface of the common femoral artery. You'll know it, and then push the wire. You don't have to use the sauce to go down. You can just push the wire so you have 15, 20 centimeters in there. Then you can just get out your sheath and reestablish yourself, right? And then you can go with sometimes trying to push the sauce isn't going to make it. There may be obstruction or whatever. I strongly encourage people to practice it. And now that, we do limb salvage patients, are worried about contrast, this and that. One leg, you can study the whole leg from one axis, and you can know what's up.
Yeah, like if you're doing a known diagnostic only angiogram, that would be a good situation to practice it on if you're going to go up and over, and then you want to do the IPSI side too.
And you'll have high quality images because you can get the catheter right down to the tibial-peroneal takeoffs and see the pedals really well. I strongly encourage mag pedals in anybody. 2 views, you got to show them. If you look at the standard competitors' workup, they have no idea. And that's a shame because those are the targets, and those are going to tell you a lot about whether there's hope or no hope, right, for that limb. So you can make some predictions. I think some reasonably accurate predictions. But I hung out in an OBL for the last year and a half in East LA. I saw the poorest of the poor are there, no alternatives. Podiatrists are supporting these things. And the minimalist technology that you have in those settings is really daunting. And that's the future, unfortunately, the minimalist infrastructure. And so 1 leg at a time, there's nothing wrong with it. You can always come back and get the other leg. Make sure you've seen the iliac arteries. I have a case I was involved in as a legal expert. The upper ear never saw the 80% iliac stenoses. I mean, it was unbelievable. Yeah. He did this beautiful recanalization of the SFA occlusion and revascularized the foot. He never saw it. And neither did the vascular surgeon or the interventional radiologist on the other side. I'm in a current case now. It's really so informative. You get inside these things. You've heard about them for 10 years, wondered, what is it really like? Oh my goodness. It's just, it's amazing. The equipment list for some of these guys on one patient's leg will be 30 things long. The IVUS of every vessel under, it's just, it's inappropriate, but it is legal. And we have to find some happy medium. We have to do better work, right? And there's hope, as long as we tell the kids, hey, you can do better than this. You don't have to be inappropriate.
Just keep pumping up the kids. You got it. We got it. Yeah. It's just like a really different environment, right? From when you came out of training. First first of all, just go back to kind of like your origin story. Like, I love that the whole time you were training, you were like, my goal is to get out, be confident that I am competent on day one. And like, that is what I care about the most. I don't care about like tons of money or fancy accolades. I just want to be a good doctor. And yeah, like, I think like a lot of us are that way and want that. There's just so much moral injury now in how we have to practice, way more administrative overhead than there was, right?
Did you just say moral injury?
Uh-oh, am I going to get in trouble? Yeah, moral injury.
No.
Yeah.
No, listen, that's a powerful phrase. I've never heard that. And I thank you for it. Because that's exactly right. So we start out, the best will start out as Boy Scouts or Girl Scouts, however you like to say it. And you meet this terrible thing. And now, for example, I get called in the middle of my day. This happens 3 or 4 times a month. Cardiologist in trouble. He's tearing up a IVC filter. I walk in the room and everybody's standing. They have more personnel than I do by 2x, right? And he's got extravasation outside the cave. He's got one leg of the filter pointed north, and he can't get it. He's been working for an hour. He says, hey, what do you think? And I said, hey, you got 6 guys next door who put them in and take them out. We're elite, like we've done thousands of these things. Who put this in? He goes, oh, your partner did. And I said, well, why are you doing this? He goes, it's my patient. And I said, oh, okay. And he says, well, can you help me now? And I said, no, I'm not going to help you now. But if you schedule this for tomorrow, we'll take it out for you. And we did. And this kind of behavior is being enabled everywhere. The hospitals don't want to know. And you have to suffer through it. And the only thing you can do is be the best you can be. You have to be exemplary. And I think that's the only high ground we have. And our patients are better for it. I don't know what to tell my son. He's coming behind me in IR.
Yeah,
and,
right, yeah.
It's a backhanded compliment. I try to prepare him for this, but that phrase is going to help me a lot. It's going to help me a lot. I'm going to explain to everyone what he's up against. They'll have a better understanding of him.
All right, you don't know this. I'm going to make a reference that's like totally not going to make any sense to you. But there's this song by Lil Wayne and Birdman called Stuntin' Like My Daddy. And I feel like you and your son should like release a remix of that called Stuntin' Like My Daddy. And like you should like record a music video for it. And I think it'd be the coolest thing ever.
Oh, that'd be funny. Well, I'll suggest it to him, but he's pretty conventional, He's going to be something. He's very impressive. Not my fault.
So that's so cool, man. That is a really, really fantastic thing that you were such a good influence on your son that he decided to follow in your profession. That's very neat.
Dude, you could go into dermatology and print money. You never have to see the inside of a hospital. You never have to rant at the dinner table about the incompetence and ineptitude that you just witnessed, that you worked so hard not to be. And he says, nah, I'm going to do what you do. It's interesting.
Amazing. Very cool.
Well, you have the same problem. You have 3 beautiful daughters and you're going to have to, guide them. Well, I was looking at you. They were bouncing all over the place. Like it was like a barrel full of monkeys. And the best time of my life was when they were 5 to 15. And I thought, you're right in the middle of that. This is the best. This is the best it's ever going to be. And so enjoy that.
It's great. Thanks. I have a good time. We have fun. We're kind of wrapping up on our hour here. I had so much fun talking to you. The last little thing I want to talk about is Harold Coons and what he meant to you and kind of what you think IR should, I don't know, maybe I can rephrase this, but I know you really wanted to kind of recognize Dr. Coons and what he's done. And that was one of the things we talked about before recording this. So what should the world know about Harold Coons?
The problem is when I start talking about him, I start to blubber. He was a giant. And I think that if you would have named the giants in the business, Katzenring, Buchstein, Ironplatz, look, there's 20 of them. Let's say there's 20 of them. And he's in the top 5. He's just an incredible visionary. And how is it that I got to stand next to that guy? Crazy. What he did is still standing for 40 years later. I can't even imagine having that kind of influence, right? And he did it without the privileges, right? He didn't have patrician parents. His father died when he was in his 40s, I think. Just extraordinary drive. When I first started with him, I was interested in whether I was getting my basketball game or whether I was going to get to my surf that week. I was just not interested in going to a meeting someplace and hanging around with a bunch of nerds. And, he was all about learning and pushing the envelope, and he didn't have the venue. If he would have been at a university, he would be God. They would be a statue. And so he made everybody think about what they did, how thoughtful they had to be. And it had to always be with the goal of doing the best thing by the patient. And man, I learned so much. And I think that's it's just the best gift anybody can give. I'm trying to give back to the residents and fellows at the U in that way, but it's not quite the close contact that you like. I'd like to do cases with them, but that's not possible because of politics and everything. But I just had dinner with him a couple weeks ago. We're not hanging out. We're not playing golf together. He's a golfer. I just can't do it. It's I'd rather blow my brains out than play 18 holes. But he's so interesting. He's still very sharp, and he's interested in the world. And the way that the Western angio community has embraced him over the long term is stunning. He's just beloved. That word, it has kind of special meaning to me. I remember it was probably the 90s, and I was watching TV late at night, and some guy who had everything was being discussed, and they were doing a movie of his life, and he was dead. He said before he died, he wanted to be beloved by those around him. I think that's a reasonable goal. And all we can do is do the best we can. We're trying to raise our families and feed them and get them ready for this crazy world that we're in. And you're doing the same thing. So anyway, I am getting off the track, but he meant so much. And I started to rectify my negligence of that about 10, 15 years. And because for a while I was competing with his reputation, his legacy, right? That guy, everything you have is because of him and all that kind of. After a while I said, no, he's just a great man, and I am so grateful to have been around him. And I'm hoping that I can leave my son or his buddies who are calling me all the time, asking me about this maneuver, just leave them a little something and a little bit about the truth of the world, because the way I see it in my hospital is not the way they see it at UC San Diego. And they're going to have to do some adjustment, and they're going to have to find a remedy for their moral injuries.
Oh man, I'm feeling very thankful that I was able to teach you something after all you have taught me. I appreciate that. That's very cool.
Yes.
Well, Dr. Alzate, we're going to wrap up our hour. It's been such a pleasure talking to you. Thanks so much for coming on the show.
All right. Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Baheti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.